So today I'm going to talk about hernias. So let's see what hernias are. So where does these hernias happen and what is this hernia? So hernia is simply a protrusion of an organ, usually intestine, through a weak point in the abdominal wall. So there are three important hernias. So one is indirect inguinal hernia. So imagine a baby before birth. So during fetal development, the testes descend from the abdomen into the scrotum through a tunnel called inguinal canal. So as they descend, they pull a finger-like pouch of the peritoneum with them. So this pouch is called processus vaginalis. So normally after birth, this tunnel closes. So if it remains open, that means if it is patent, it becomes a ready-made pathway for intestine. So this product produces as an indirect inguinal hernia. So the intestine follows exactly the same route that testes once followed. So what happens is in indirect inguinal hernia, they forget to close the door. So in a baby, the testes descend from the abdomen into the scrotum to a tunnel called inguinal canal. So as they descend, they take some peritoneum with them. So that is the normal procedure. So this pouch is known as processus vaginalis. So if you have ever heard about this, this is processus vaginalis. So normally after birth this tunnel should close, but it doesn't happen in every person. So but in some people it becomes remains open. That means patent. So it becomes, if it is open or patent, it becomes a ready-made pathway for the intestine to protrude. So this produces an indirect inguinal hernia. So the intestine follows exactly the same route that testes once followed. So testes are the ones who came, but now the intestine also go with the testes. So the path is from deep inguinal ring via inguinal canal to the superficial inguinal ring to the scrotum. So if this is a girl or a female, this is labium majus. So indirect hernia travels to the entire inguinal canal. So why is it called indirect? Because it doesn't push directly through the abdominal wall. So instead it takes a long detour using an already existing tunnel. So it is like this. Think of it like a thief entering a house through the front gate instead of breaking the wall. So they forgot to close the gate. If they did close it, then the thief wouldn't come. But as they forgot to close it, the thief will come directly through the gate. So it is like a detour. That means thief has to find the door and come in. It is not like the thief can break the wall and come in. So it is indirect. So if it is just breaking the wall and coming in, the thief can come directly. But now thief has to find the door and then come in. So it is called as indirect. So what is the relation to the inferior epigastric artery? So the deep ring lies lateral to the inferior epigastric vessels. So since the hernia enters through the deep ring, indirect hernia is always lateral to the inferior epigastric artery. So that means the deep ring, the door lies the door lies lateral to the inferior epigastric vessels. So as this hernia or as this thief comes from the door, so that means this thief is also lateral to the inferior epigastric artery. So remember it as LI. Indirect one is lateral to the epigastric vessels. So how to test it? So the examiner places a finger through the superficial ring toward the deep ring. So when the patient coughs, the hernia comes out and canal strikes the tip of the finger. So if we strike the tip of the finger, we call it that indirect. Tip, so it is like tip, indirect. Tip, indirect. Because remember TI, so tip, and then I is for indirect. And what is direct inguinal hernia? So this one is completely different. So that means there's no congenital tunnel. That means there's no birth defect. Instead, years of increased abdominal pressure due to cough, lifting heavy weights, or due to age, it weakens the posterior wall of the inguinal canal, and eventually the intestine simply pushes straight through it. So imagine pushing your finger through a weak cardboard. So there's no tunnel, no data, just straight through. Hence, we call it as direct hernia. So now the thief is coming straight into the house by breaking down the wall because that part of the wall is weak. So there's this place is called as Hustle Park Strangle. So the boundaries are medial just rectus abdominis, lateral just inferior epigastric vessels, and inferiorly there's inguinal ligament. So this triangle is naturally weak. So this part of the wall is naturally weak. So the thief breaks down the wall directly without finding where the gate is. It breaks down the wall directly and comes in. So medially he can see the rectus abdominis, laterally he can see the inferior epigastric vessels, inferiorly he can see the inguinal ligament. So direction to the inferior epigastric artery is this weak area, the Hasselbalch triangle is medial to the artery. So the direct hernia should be medial to the artery. So remember it as MD. Medial means direct. So what is a test? So when coughing, this funny pushes against the side, palp of the finger instead of the tip. So if it touches the palp, that means direct. If it touches the tip, it is indirect. So tip means TIP, right? So tip I is for indirect. And there's another hernia that is called femoral hernia. So now imagine the intestine ignores the inguinal canal completely. Instead, it slips underneath the inguinal ligament. It enters a tiny opening called the femoral ring, then travels into the femoral canal. So here what happens? It goes under the inguinal ligament. That's a uh, completely different part. It is like uh, in a tunnel in a basement tunnel or underground tunnel. It goes in. So this is below the inguinal ligament, and this is below and lateral to the pubic tubercle. So inguinal hernia is above and medial to the pubic tubercle, while femoral hernia is below and lateral to the pubic tubercle. And also this is common in women. Why is that? Because they have wider pelvis, large femoral canal, so therefore the opening is larger. So, and also this is dangerous because the femoral ring has rigid boundaries. So once the intestine gets trapped in it, the blood supply is cut off easily. So therefore, the femoral hernia has a greater risk. So it is like taking up a underground pathway, but underground has rigid boundaries. So if that teeth becomes trapped inside this, so he can't um, like he won't get enough oxygen. So it is highly risky. And then we'll talk about the lesser omentum. So now enter the abdominal cavity. So stomach is like hanging like a bag, and liver sits above it. So the lesser omentum is simply a double fold of peritoneum connecting these two organs. So think of it as a curtain hanging between liver and stomach. So attachments are upper attachment is for the hepatis and fissure of the ligamentum venosus. Lower attachment are lesser curvature of the stomach and first 2 centimeters of the duodenum. So there are two parts hepatogastric ligament where it connects the liver and the stomach. So hepato means liver, gastric means stomach, that is thin and broad. And hepatoduodenal ligament is liver and duodenum, that is short and thin. And then we got the portal triad. So inside the hepatoduodenal ligament, there are three structures inside the hepatoduodenal ligament. So think of it as like three pipes entering the liver. So portal vein, it brings nutrient-rich blood, and then we get proper hepatic artery. So that brings oxygen-rich blood, and common hepatic duct that carries bile away. So the arrangement is classically front right, there's bile duct, front left, there's hepatic artery, behind both is the portal vein. So duct right, artery left, vein behind. Remember it like that. Duct right, artery left, vein behind. And lesser sac is behind the stomach. There's a hiding pocket. This is called the lesser sacco-omental bursa. So the anterior wall is formed mainly by stomach and the lesser omentum. And there's another thing called epiploid or Bill's foramen. So this is the only natural doorway connecting the great and lesser sacs. So the boundaries are anteriorly hepatoduodenal ligament, posteriorly inferior vena cava, superiorly caudate lobe of the liver, inferiorly first part of the duodenum. So portal vein after digestion, blood from the intestine contains glucose, amino acid, vitamins, toxins. So instead of going directly to the heart, all of this blood first goes to the liver. So liver acts as a body's processing factory. So this vessel that carries this is portal vein. So where is it formed? It is formed behind the neck of the pancreas. So portal vein forms by joining superior mesenteric vein with the splenic vein at the transpyloric plane. So you know the transpyloric plane, that means L1. And I also taught you a way to remember the things in the transpyloric plane. That is, please pass Paul's factories so that uh, the spinal ducts won't kill good ninth graders. That means please pass Paul's pancreas. So pyloric of the stomach and pancreas and neck of the pancreas, not pancreas, neck of the pancreas, and portal vein and origin of the superior mesenteric artery and the finishing of the spinal cord, and we got the fundus of the gallbladder, uh, and the ninth costal cartilage, and likewise we will remember those. There are more as gallbladder and vertebra and portal vein and mesenteric artery, costal cartilages, stomach pylorus, and first part of the duodenum. Yeah. So here the inferior mesenteric vein usually drains into the splenic vein before the union. So the tributaries of portal vein is left gastric vein, right gastric vein, cystic veins, paraumbilical veins, and also uh, superior mesenteric vein and splenic vein. And also there's no valves in portal vein because portal blood must flow freely according to pressure changes. If there were valves would obstruct this. So portal hypertension is that suppose the cirrhosis causes the liver, so blood cannot flow through easily. So pressure rises because there's a blockage. This is called portal hypertension. So the blood then searches for an alternative route back to the heart. So those routes are called the portosystemic or portocaval anastomosis. So esophageal varices, portal vein, left gastric vein connects with the systemic esophageal vein. So the veins enlarge and become varices. If they rupture, there will be a massive upper gastrointestinal bleeding, hematemesis, making this a medical injury. So left gastric vein connects with the systemic esophageal vein. And we have to learn about the carpet medusa. So the portal paraumbilical veins connect with the systemic, superior and inferior epigastric veins. So the veins around the umbilicus becomes enlarged and radiate outward like snakes on Medusa's head. Hence the name Carpet Medusa, head of Medusa. is um, produced. So it is like a medulla, the things are like the appendages are like coming from one place and in a weird manner, right? So this happens when the veins around the umbilicus becomes enlarged and radiate outward like snakes on the medulla's head. So it is portal paraumbilical veins connecting with the systemic, superficial and inferior epigastric veins. And also internal hemorrhoids can happen. That means portal superior rectal vein connects with the systemic, middle and inferior rectal vein. So increased pressure dilates the internal rectal venous flexus, contributing to internal hemorrhoids. So superior rectal vein connects with the systemic, middle and inferior rectal vein. So increased pressure dilates the internal rectal venous plexus, contributing to internal hemorrhoid. And then there's Pringle's maneuver. That is like imagine severe bleeding from the liver during surgery. So the surgeon places a finger around the free edge of the lesser omentum, the hepatoduodenal ligament, and compresses it. This temporarily blocks the portal vein, proper hepatic artery, and this greatly reduces the blood flow into the liver and helps to control the hemorrhage. If bleeding continues despite this maneuver, the source is likely from the hepatic vein, so the inferior vena cava rather than the portal turret. So yes, if when the surgeon places a finger on the free edge of the lesser omentum, the hepatoduodenal ligament where the portal turret is there, and compresses it, if this blocks the bleeding, that means it should be proper portal vein or proper hepatic artery. Otherwise, it should be something else. It can be a hepatic vein, so the inferior vena cava rather than the portal tract. And then we have something called ligamentum teres. So before birth, the left umbilical vein carries oxygenated blood from placenta to the fetus. So the after birth, it closes and becomes ligamentum teres hepatis around the ligament of liver, located in the free edge of the falciform ligament. So in some adults, it can be reopened, recanalized, or cannulated to gain access to the portal venous system for certain procedures. And then last thing is ascites. So when the portal pressure becomes very high, increased hydrostatic pressure pushes the fluid out of the portal circulation. So ascites means increasing hydrostatic pressure that pushes the portal fluid out of the portal circulation. And also when the liver is diseased, it produces less albumin. So albumin is needed for the uh, plasma oncotic pressure. It will pull water in and it will prevent it from going to the uh, interstitial space. But here, when the liver is also diseased, it won't produce enough albumin, so it will lower the plasma oncotic pressure. And this combination causes fluid to accumulate in the peritoneal cavity. So what combination is this? Because liver is diseased, so that the it can't produce enough albumin, and also increased hydrostatic pressure due to the blockage.